Greetings. My name is Stephen Hooper, and I'm a professor at the University of North Carolina School of Medicine. I'm also the Associate Dean and Chairperson of the Department of Allied Health Sciences at the University of North Carolina School of Medicine. In addition, I hold an adjunct professorship in the Department of Psychiatry at Duke University Medical Center. I am pleased today to talk to you about Module 2, which is dedicated to examining neurocognitive, academic, and social behavioral characteristics of individuals with 22q11 deletion syndrome. This module is part of a three-part series devoted to addressing issues pertinent to 22q deletion syndrome. Module 1 is for a variety of professionals, but especially tailored to primary care providers and has a decidedly medical emphasis. Module 3 is for a variety of professionals as well, including primary care providers, allied health providers, and educators, and has a clear focus on a family emphasis and a family perspective on this genetic condition. Module 2 is entitled Neurocognitive, Academic, and Social Behavioral Characteristics of Individuals with 22q11 deletion syndrome across the lifespan. And as we begin, I want to acknowledge the gracious support from the Dempster Family Foundation for the development of not only Module 2, but this three-part series. As we begin, Module 2 is primarily for educators, but is also relevant to the practice of pediatricians and other medical providers. Module 2 is designed to complement the content contained in Modules 1 and Module 3. Contained within Module 2 are a number of salient issues. We will briefly have a definition of 22q11 deletion syndrome. We will take a look at development across the lifespan, moving from the preschool, infant, and toddler years through the geriatric years. We will spend time examining features such as the neurocognitive capabilities of many individuals with this condition, academic skills, and social behavioral functioning. Additionally, we will spend time examining and discussing measurement and evaluation strategies, as well as management and intervention approaches for this population. So let's begin. What is 22q11 deletion syndrome? You will have covered a variety of these features in Module 1 if you've had the opportunity to review that module. But briefly, for Module 2, chromosome 22q is a genetic disorder caused by a hemizygous deletion within the long arm of chromosome 22. The term hemizygous refers to an individual who only has one allele of a gene or chromosome segment rather than the usual two. About 90% of individuals with 22q11 deletion syndrome are sporadic. The mechanism of how and why this sporadic deletion occurs remains unknown at present. For the remaining 10% of cases, however, one of the parents has the deletion, and the child has inherited this condition. The parent with the deletion often has mild features and, interestingly, typically is not diagnosed until after the child receives his or her diagnosis. This can present a variety of interesting situations within a family, and these types of situations should be carefully dealt with by the designated professional. 22q11 deletion syndrome is a genetic disorder caused by a hemizygous deletion within the long arm of chromosome 22. The term hemizygous refers to an individual who has only one allele of a gene or chromosome segment rather than the usual two. About 90% of cases are sporadic in nature. That is, the mechanism of how and why this sporadic deletion occurs remains unknown. For the remaining 10% of cases, one of the parents has 22q11 deletion syndrome, and the child has inherited this deletion. The parent with the deletion often has mild features and generally is not diagnosed until after the child receives his or her diagnosis. This can present a variety of interesting scenarios for the clinician in terms of how this will be managed within the family. 22q11 deletion syndrome is the second most common autosomal chromosomal microdeletion in humans. This is far more common than one might imagine and is second only to Down syndrome, with approximately a 1 in 2,000 individuals rate of occurrence. In addition, it's important to know that this deletion is known by a variety of other names. One of the more prominent ones that you will see is velocardiofacial syndrome, or VCFS, DiGeorge syndrome, Catch-22 syndrome, conal truncal anomaly face syndrome, Sprinson syndrome, and a variety of other names. Individuals with this deletion can manifest a variety of medical conditions that also can include congenital heart disease, palatal anomalies, hypocalcemia, and T-cell immunodeficiencies. These medical conditions can create a variety of concerns, not only with respect to the medical care and management of children, but also long-term effects in terms of medical adherence and health. Individuals with 22q also can manifest a variety of neurodevelopmental difficulties that can include abnormal development across the lifespan, neurocognitive impairments, academic skill deficits, and social, behavioral, and psychiatric challenges. Taken together, an individual with 22q11 deletion syndrome actually can have a variety of risk factors as they move forward in their development. So let's turn our attentions to development across the lifespan for many individuals with this deletion. For infancy, this is a time of extreme excitement for most families, having a newborn into the family. Families with newborns and infants who have been diagnosed with 22q may have to focus on a variety of concerns that other families without this condition will not experience. Serious medical complications, in particular, make the developmental milestones of initial secondary concern for families. Those families of newborns and infants who do not have serious medical conditions may notice early developmental delays and lags. Specific developmental problems can include delayed speech actions such as babbling and gesturing, feeding issues, perhaps secondary to the cleft lip and palate problems that can be seen in many of these children. The effects on families and development with these types of initial problems can be profound, and the impact of feeding challenges for a newborn cannot be underestimated. Many newborns will have difficulty tracking objects with their eyes, coordinating limb movements. Many may show hypotonia or low muscle tone, and they may show primitive reflexes that last longer than expected, such as increased and longer presence of a startle reflex. Older babies with the condition might have delays in sitting, walking, perhaps even saying their first words or speaking in short sentences. It is at this time that many parents may approach their primary care provider with respect to early screening for these concerns. As the children age into the toddler and preschool period, roughly ages 2 and 3, toddlers and preschoolers with 22q11 may have difficulties including talking in complete sentences. Their problem solving and understanding of cause and effect relationships may be different or delayed in their appearance. Given the early motor concerns with hypotonia, many children may go on to experience fine motor coordination or perhaps gross motor difficulties. You may also see emergent problems in social interactions. Children with 22q also may have emergent behavioral issues, such as being quick to anger or becoming easily frustrated. These problems in the 2 to 3 toddler years or the 3 to 5 age preschool years typically are manifested in the school setting and may first come to light in a preschool setting. Moving into childhood, roughly ages 5 through 12, these symptoms and outcomes are variable, making psychological, behavioral, and academic testing an essential tool in helping families to advocate for student services. Many children may require special education services, but a number of children with the condition may actually perform adequately in the regular classroom situation with selected supports and accommodations. Nonetheless, we will discuss later some specific assessment strategies that might be helpful for many individuals with 22q. Given the age, academic difficulties and learning needs are likely to emerge in the school setting, and/or they may change as the child matures. Some deficits, such as executive difficulties, may actually not manifest their full impact until the child reaches late childhood or early adolescence. Common academic and cognitive issues can include math disabilities or challenges with math content, which may persist even with intervention. Reading comprehension deficits, particularly with figurative language. Difficulty with verbal expression. Troubles understanding complex directions or perhaps recalling information. Many children with 22q will have a lower IQ with a possible decline in verbal IQ scores during the school-age years. A select percent of children may also have intellectual disabilities. Attention problems seem to be prevalent across many children with 22q, with many children receiving the diagnosis of attention deficit hyperactivity deficit disorder. Another interesting feature that tends to emerge in the preschool and perhaps more commonly during the childhood years is the presence of autism spectrum disorder symptoms. This disorder has been described in approximately 10% of cases. However, it's important to note that there's some associated controversy with respect to its actual overlap. There are data noting that this overlap does exist, with symptoms occurring in many individuals in the disorder appearing in about 10% of cases. But there are also additional data suggesting that with adequate and thorough assessment of autism spectrum symptoms, that indeed the prevalence is not much more than typically seen in the general population. So we will need to see how this story plays out with respect to this overlap with additional research. Just as academic challenges during childhood are likely to change over time, so might the child's behavioral and emotional strengths and weaknesses. These challenges can include a variety of concerns, including social lags or social immaturity. Again, the presence of impulsivity or perhaps diagnosed attention deficit hyperactivity disorder. The child may experience difficulty regulating their moods. In particular, anxiety is a major problem for a large percentage of children with 22q11, and this can include obsessive-compulsive symptoms or obsessive-compulsive disorder, along with a number of specific phobias. Affective conditions such as major depressive disorder or dysthymia also can be present with respect to mood regulation difficulties. Social problems, such as the ability to make friends or maintain friendships or navigate conflicts with friends, also can be challenging during childhood. Social cognitive deficits can also be present, perhaps as part of the neurocognitive profile, and can include the difficulty of reading nonverbal emotional cues. As a child moves into adolescence, roughly ages 13 to 19, issues that occurred in childhood often persist. In addition to those conditions, symptoms, and disorders previously mentioned for childhood, some children might be diagnosed with other emotional, behavior, or psychiatric conditions during adolescence. These issues might include the presence of dysthymia, depression, or perhaps even bipolar disorder with features showing mania or hypomania being prevalent. Some symptoms may be attenuated with diagnosis of the disorder, and subsequently treatment with therapy and medication may be very useful in terms of management during these years. With the influx of hormones during adolescence, these types of difficulties can be very difficult to diagnose and treat. As children and adolescents mature into adulthood, perhaps one of the worrisome features for parents of children with 22q is the emergence of psychotic disorders or schizophrenia symptoms in late adolescence and late adulthood. The general age of onset of these types of serious psychiatric symptoms is approximately 18 years, with significant variability into early adulthood. For women, it tends to be earlier that these symptoms appear, and for men, it appears to be in the mid-20s. In general, the risk rate increases to about 25% for these symptoms will appear in this population during adulthood. In contrast, in the normal developing population, schizophrenia occurs at an incidence rate of approximately 1%. This stands in stark contrast to the 25% that can be seen in 22q syndrome. As this population ages, it becomes a new frontier for examination of not only issues such as health and lifespan, but how these neurocognitive and social behavioral features manifest. As individuals age into the middle age and senior age periods, we don't have a lot of data, but suffice it to say that these symptoms and features that are accompanying 22q will continue. What data we do have suggests that lifespans can be relatively normal, but individuals with 22q who survive childhood can have diminished life expectancy. One study actually has documented an increased risk of sudden death not attributable to any factor, and this is of concern as individuals age. The range of challenges that older individuals with 22q may experience is currently unknown. And as they bring cardiac issues, psychiatric status, and increased medical risk, including early onset Parkinson's disease, as per one study, this is an area that must be investigated with respect to moving forward in our understanding of 22q across the lifespan. Now, with that developmental overview, I'd like to turn my attentions to discussing a little bit about the features inherent in 22q. And again, designed to complement what is in Modules 1 and Modules 3, I want to spend a little bit of time talking about neurocognitive function and academic and social behavioral skills. Let's begin with neurocognitive functioning. Neurocognitive deficits consistently have been reported in children and adolescents with 22q. The neurocognitive profile of individuals with this condition has been associated with a particular kind of learning disability paradigm called the nonverbal learning disability model. This profile comprises neurocognitive features including verbal abilities typically being higher than nonverbal abilities. This includes core language functions being more intact than visual spatial abilities, and functions such as verbal memory typically being higher than visual memory. The profile includes disproportionately lower sensory motor functions on the left side of the body. In line with the nonverbal learning disability paradigm, this begins to implicate right hemisphere dysfunction as a primary area of concern for this condition. Reading and math skills are divergent, with reading and spelling skills tending to be higher than basic math skills. And interestingly, according to this model, there is an increased internalizing type of psychopathology that can be manifest. Internalizing types of psychopathology can include anxiety and affective disorders. The nonverbal profile describes approximately 25% of individuals with this condition. This is interesting in that, as a heuristic, it works very nicely in beginning to gain understanding of this population. In fact, what we know is most individuals with 22q will show deficits or lags in nearly every neurocognitive domain, including a lower level of IQ with ranges widely varying from average to intellectual disability. Attention can vary widely. Language, visual processing, memory, all are areas that can manifest in dysfunction or impairment, and executive dysfunction and social cognition difficulties can be present. Again, while the nonverbal learning disability model does provide a paradigm in terms of understanding the general features of 22q, heterogeneity in the neurocognitive abilities for the majority of individuals should be the rule. Regardless of the profile, the neurocognitive deficits in this population are suspected as worsening over time. There have been a few longitudinal studies to date to show this. Gothelf and colleagues have shown declines in verbal IQ and expressive language over a 5-year time period. Cates and her colleagues have reported verbal IQ declines over a 3-year time period, and Voortsman and colleagues have shown declines in verbal IQ in a large international sample. Taken together, these groups noted that declines could be related to changes in brain structure, for example, issues of cortical thickness. They also could be related to emergent psychopathology, such as what might be seen in prodromal psychotic symptom phase, or perhaps, in a more complex understanding, a genetic by neurodevelopmental interaction. Green and colleagues noted that the need for ongoing prospective longitudinal studies are paramount to understand this potential decline in function more clearly. Our group at Duke has showed that over a 3.5-year time span, that overall measures of neurocognitive ability do not necessarily improve, but rather remain stable and low. The stability was evident in overall intellectual functioning, language and visual spatial abilities, verbal memory and learning, and selected executive functions such as problem solving, planning, and verbal working memory. In contrast, our group has demonstrated, along with the earlier studies just noted, significant declines in two primary areas: attention regulation and processing speed. The declines in attention regulation and processing speed complement the findings related to declines in verbal IQ and expressive language. And it is suspected that declines in processing speed also could be related to the early hypotonia and fine motor deficits that children can experience. As a question, we wonder if these cognitive underpinnings reflect changes in brain structure and function, and could these represent potential predictors of increased psychiatric difficulties and potential prodromal symptoms as children move into late adolescence and young adulthood. We know from available data that declines in verbal IQ have been associated with increased vulnerability to the emergence of psychotic symptoms and schizophrenia in late adolescence or early adulthood. These are perplexing and complex questions that will require large samples to study. In addition to the neurocognitive deficits, social cognitive impairments also have begun to be documented. These deficits manifest in how individuals express affective information, as well as in how individuals understand affective information. These deficits, if present, will be reflected in poor social skills, poor social adjustment, and poor social decision-making. All in all, this combination of problems can contribute to poor peer relationships and social adjustment difficulties across the lifespan. Additionally, some have questioned if these types of difficulties can contribute to potentially increased psychiatric illness over time. Let's turn our attentions now to social behavioral functions. In the 22q population, suffice it to say that there are high rates of social behavioral problems. In general, there tends to be more internalizing types of behavioral issues than externalizing problems. That is, there tends to be more anxiety and depressive types of problems than you might see with individuals who might be acting out or showing conduct difficulties. This is consistent with the nonverbal learning disability paradigm mentioned earlier. Weaker social competence also has been reported along with increased social problems. Again, these types of difficulties seem to run together because one can lead to the other. In general, these problems tend to be only partially related to IQ and medical complications, and indeed may have their own neurologic substrates with respect to the phenotypic presentation of individuals with 22q deletion syndrome. We know that over 60% of adolescents show at least one psychiatric disorder. Common psychiatric conditions in individuals include, as mentioned earlier, attention deficit hyperactivity disorder, anxiety disorders, including specific phobias and obsessive compulsive disorder, affective disorders, in some instances, oppositional defiant disorder, and again, the controversial inclusion of autism spectrum disorder. Again, the latter issue may be an artifact of measurement, or perhaps it may have true overlap with the condition. Anxiety disorders and ADHD at this point in time appear to be most common in childhood and adolescence. And again, symptoms of autism spectrum disorder tend to be described, but the presence of these symptoms remains debated. Perhaps of most interest in this population is the strong linkage to the later emergence of psychotic symptoms and perhaps full-blown schizophrenia. 30 to 40% of patients with 22q are noted to have a major psychosis in late teen and early adulthood years, with about a quarter of the population receiving a formal diagnosis on the schizophrenia spectrum. And no other genetic condition is such risk evident. And again, with only 1% of the general population manifesting schizophrenia, this becomes a very interesting genetic condition for the study of psychosis and schizophrenia. 1 to 6% of patients with schizophrenia actually will manifest this genetic condition. In general, onset tends to manifest in adolescence to early adulthood, but has been reported as early as the mid-teens. Negative and positive symptoms similar to the disorder in the general population has been described. In general, schizophrenia is thought to be the result of abnormal neurodevelopment, and 22q is clearly consistent with this understanding. It is likely that a combination of genetic and environmental factors progressively culminate in the emergence of schizophrenia and/or psychotic symptoms. The genetic contributions to this are not fully understood, and again, linkage to the 22q11.2 region in some families with schizophrenia becomes of keen interest. Neuropsychological abnormalities and structural brain findings have been reported to precede these symptoms in the schizophrenia spectrum disorder. Response to antipsychotics in this population have been suspected as being similar as in the general population. However, there have been no long-term efficacy studies on the effectiveness of these medications with the 22q population. Some studies have been conducted showing benefit, but the long-term efficacy studies need to be conducted. Taken together with the social issues and the neurocognitive problems, many children, as they enter school, show significant academic challenges. The focus of much of the research of 22q has been on the neurocognitive and psychiatric features of this condition. Less focus has been placed on academic functioning and school adjustment, which perhaps predictably also is an area of difficulty for many, many individuals with 22q syndrome. The available research has shown specific deficits in mathematics with relatively better reading and spelling abilities. Again, this is consistent with what would be projected from the nonverbal learning disability paradigm. However, it's important to note as we go through the next several slides that many children with 22q suffer with academic deficits across all academic areas. Deficits in math in children with 22q have been shown to be related more to procedural difficulties than fact retrieval. Retrieving basic arithmetic facts tends to be faster than when borrowing and carrying numbers is required to complete a calculation. So as tasks become more complex and attention and working memory begin to be involved in basic arithmetic calculations, additional challenges may be experienced by children with 22q. In addition, many individuals also show greater difficulty with word problems and comparing the magnitude of numbers and an estimation. When we look at the reading area, again, the general sense is that reading and spelling skills tend to be better than math skills. But studies investigating reading are relatively sparse. What data are available present mixed findings in the literature. For example, overall average pre-reading skills are present. However, children can show relatively lower phonologic awareness. Children can manifest significantly better word reading skills, but their reading comprehension skills tend to be lagged or impaired. And the reading comprehension level has been reported in some studies to be equivalent to the word reading level. This presents a mixed profile with understanding what to do with a reading challenge for children with 22q. With respect to academic skills, a recent study by our group revealed a number of interesting findings. We found that the overall academic level was in the borderline to low average range. Yes, we did find the reading and spelling skills to be better in general than the math skills. But there were some caveats to that I will mention later. There was a high rate of learning problems when you define learning problems by children falling in the bottom quartile. When we look at the bottom quartile, 87% of children with 22q experienced math difficulties, 67% experienced reading difficulties, and about a third experienced spelling difficulties. When the criterion of an average IQ was applied, these numbers dwindled, with math still being at 16% and reading and spelling being at 3% and 2% respectively. This is because the majority of children with 22q do not have an average IQ. When we look at the bottom quartile, it is clear that a large percentage of these children are struggling in reading, math, and even spelling. An analysis of critical academic skills showed a number of interesting findings relating to the reading, spelling, and math comparison. Reading comprehension was very interesting with respect to the differential between literal and inferential comprehension. Numerical operations parsed out in terms of basic concepts, basic math and algebra and geometry, with the basic math concepts coming online relatively early, but the more complex math remaining difficult over time. This included multiplication and math reasoning. Additionally, despite the majority of children with 22q performing in the lowest quartile when compared to their peers, very few met criteria for the low achievement definition of a learning disability. This raises questions for what school-based services should be provided to children with this condition, but it is clear that educational needs are prevalent for many children with 22q11. Increased examination of the neurologic underpinnings for these associated learning problems is warranted. As we move on into understanding this condition in Module 2, let me spend a little bit of time discussing measurement and evaluation, and of course, how this relates to intervention strategies and approaches. Measurement and evaluation is critical for this population, and it should be obtained as early as possible in the developmental lifespan of these youngsters. Individuals with 22q should receive comprehensive evaluations of not only their neurocognitive and academic areas, but also their psychiatric status. Even in situations where there are problems not being reported, ongoing developmental surveillance is critical. These evaluations should begin early in life, and they should be conducted at regular intervals as part of the developmental surveillance of routine medical management for children with this genetic condition. Neurocognitive measures should be comprehensive in nature. At this point, many batteries have been derived from the NIMH matrix battery and include measures such as IQ, attention, language, visual spatial abilities, memory, and executive functions. The NIMH matrix battery is important because it was developed for individuals with schizophrenia. Given the high rate of appearance of schizophrenia as individuals age into late adolescence and young adulthood, this becomes a way of providing a developmental breadcrumb trail to track change over time. Other examples can include standardized batteries such as the Wechsler Intelligence Scale for Children, with the newest edition coming out, California Verbal Learning Test, and Wisconsin Card Sorting Test. Similarly, academic skills need to be assessed on a regular basis, and in particular, these need to be assessed in detail, because as we've shown in our study, these skills not only can be low, but they can be variable within and across skill sets. Academic skills should be conducted as part of ongoing progress monitoring for every child. A particular focus for this population should be on the full range of math skills, but also on higher order reading comprehension and basic reading skills for the youngest of children. Given the risk for most individuals with 22q to experience academic skill deficits and school dysfunction, early assessment and associated intervention should be pursued. Similarly, social behavioral functions and associated psychiatric status should be assessed on a regular basis. As noted earlier, this should occur even if there are no indications of psychiatric or behavioral symptoms. The presence of neurocognitive problems and perhaps associated academic problems present risk factors for later behavioral adjustment problems and perhaps later psychiatric difficulties. This is particularly true with lower verbal IQ and executive function impairments being noted. And indeed, if verbal IQ, attention, processing speed, and other cognitive functions are suspected of as declining, this will become a moving target for educators, primary care providers, and parents. Measurement of social behavioral functions and psychiatric difficulties should be conducted by a trained mental health professional and can be obtained using a variety of different rating scales, semi-structured interviews, and clinical interviews. In particular, a multi-rater, multi-setting, and multi-instrument approach is preferred, so as to get information across different settings and different instruments for the individual when looking at psychiatric manifestation. Family functioning should never be neglected in this aspect of the evaluation. You will hear more about this in Module 3, but suffice it to say that the family functioning is going to be a critical component of the child's mental health functioning. Let's turn our attentions to management and interventions. First of all, it's very important, coming on the heels of a comprehensive assessment, to understand how the neurocognitive, academic, and psychiatric manifestations are being evident across each of the developmental stages. This is going to have important implications for academic instruction, vocational adjustments, and perhaps medical compliance and adherence. This will be particularly important for psychiatric conditions that emerge in terms of keeping the environment stable and the neurocognitive abilities intact at their functional level and not at stress levels. Emergent evidence suggesting that positive changes can be made using cognitive rehabilitation strategies have begun to be seen. In a study in our laboratory, we have shown that after 12 weeks of computer-based intervention, adolescents showed positive gains in their attention regulation and working memory. The computer-based intervention was designed to address these specific areas of weakness in the broader 22q phenotype. And indeed, with practice, it appears that these areas of cognitive functioning can improve. Targeted educational services also should be provided across a range of possibilities depending on the child's educational needs. These possibilities can include a range of academic services, including a special education provision that would permit the development of an individual education plan to address targeted needs, a 504 plan, which will level the playing field with respect to classroom accommodations and adjustments. Some families or schools may provide tutoring or other academic or social accommodations to address academic lags. In fact, there may be some children with 22q syndrome who participate in the regular education setting and may actually perform relatively adequately with perhaps occasional supports. Without a comprehensive assessment and understanding the range of difficulties and the severity of the difficulties, in fact, these types of decisions will be more difficult to be made. Specific academic interventions can include a variety of information, and there are some nice resources available. The text by Donna Cutler-Landsman in particular provides an array of possibilities to be used with this population across the school years. For example, an early intervention for reading skills. At the preschool level, this will include keen attention to such functions as phonologic processing, which relates to the detection and manipulation of sounds, vocabulary development, and emergent phonics, which is the sound-symbol associations needed for word decoding. Moving into the school-age years, there's significant evidence suggesting that a phonologic-based intervention may prove quite useful in the development of reading skills for all children, and perhaps including children with 22q. In the presence of language impairments, specific language interventions also may be useful depending on the degree of language involvement for a particular child. Similarly, the development of receptive language may facilitate the emergence of reading comprehension, and a language intervention program may include direct instruction related to developing these skills. Indeed, with preschool focus on vocabulary, as well as in the early elementary years, this becomes a component of receptive capability. As we know, there are some difficulties with higher order comprehension for many individuals with 22q, and ongoing scaffolding of higher order comprehension will be essentially, especially with figurative types of language. It'll also be careful, given the cognitive capacity for many children with 22q, to be careful with the size of the informational chunks so as to minimize the student's feelings of being overwhelmed and flooded and consequently not processing any of the information. With longer reading passages, techniques such as online comprehension strategies may work well to facilitate overall understanding of what is being said. In general, online comprehension strategies work to chunk the information, ask children about what they just read with respect to their understanding, and offers the opportunity to ask what might happen next in the passage before continuing the reading of the passage. If core phonologic processes are disrupted, it is likely that spelling and written language skills may be impaired as well. Facilitating ideation will be important to written output, with multiple drafts of written output being encouraged. Evidence-based instructional strategies, such as the Self-Regulated Strategy Development Model, or SRSD, have been shown to be quite significant for children with a variety of learning difficulties and may prove useful in developing writing skills for students with 22q. And in particular, this type of approach may be particularly relevant for students who also show concomitant executive dysfunctions. Specifically, the SR-SD model is a model wherein individuals are taught an overarching strategy to learn specific strategies with respect to content domain. There are three major components that can be seen. There are 6 stages of explicit instruction that include development of background knowledge, discussing the background knowledge, modeling it, memorizing it, having it supported, and then independent performance. Secondly, explicit instruction and self-regulation strategies, including goal setting, self-monitoring, and self-instruction. Again, for a youngster with executive deficits, these types of interventions become critical. And the third major component of SRSD is the development of positive self-efficacy about using this model. In general, the SRSD model is a strategy to learn additional strategies. It has been shown to be extraordinarily effective in the development of written language capabilities, but also may have applications to other areas such as behavioral function. Written language is considered a problem-solving process that involves planning, knowledge transfer, and various skills. The SRSD approach goes directly after these capabilities with respect to written language and has the advantage of addressing some of the areas of weakness that have been described in individuals with 22q. The model distinguishes itself from alphabetical principle-based interventions. The SRSD model is developmentally appropriate for a wide range of students, and again, significant positive data have been documented for students with writing disabilities and behavior disorders, and holds promise for teaching other self-regulatory skills, particularly for individuals with 22q. As noted, math has been identified as a weakness in most individuals with 22q. The development of basic math skills should begin in the preschool years with overlearning of basic math facts and calculation skills. The overlearning is critical as it will contribute to facts being automatized. The more automatized these basic skills, the more cognitive resources that will be available to the student for the other problem-solving aspects of math, such as borrowing and carrying. Additionally, working to facilitate sequences and organization of math input and output become critical. Remember, in addition to the spatial deficits and some of the executive issues that can be seen in individuals with 22q, there can be a reading component to math problem solving. Ongoing assistance for higher order math skills likely will be required for many students. This will include making sure that they can understand what is being read, and the degree of assistance likely will go beyond that of typical instruction and tutoring. This may be necessary for a student in order to satisfy curriculum goals and objectives, and perhaps even for high school graduation requirements. In addition to potential struggles in reading, writing, and math, remember that as the student moves into middle school and high school learning environments, the demand for these basic skills in other content areas, such as social studies and science, may hinder progress in these other areas as well. It will be important for parents and teachers to plan accordingly with respect to addressing these learning needs in the presence of core literacy and math difficulties. Indeed, this may require creative classroom environment, creative classroom accommodations, and significant patience in order to facilitate this content learning. As we've discussed, with respect to features, social behavioral difficulties are pervasive and, from a management and intervention perspective, will require ongoing treatment and scaffolding via parents and teachers. Pharmacologic interventions are routinely used, but we have few controlled studies or randomized controlled trials to truly assess their effectiveness. To complicate matters, we also know little about how associated comorbidities may affect the impact of a pharmacologic intervention. We also don't know how side effects affect neurocognition and learning for children who are on multiple pharmacologic treatments. We know that there's evidence-based interventions that are needed, and data regarding these are lacking at this juncture, but some studies are emergent. In a pilot study by our group at Duke, we have utilized social cognitive training to show positive effects on the individual's affective regulation and pragmatic skills. Unfortunately, many individuals with 22q and associated psychiatric diagnoses do not receive social behavioral interventions. In fact, they don't receive the social behavioral interventions even at the same rate as typical individuals who are experiencing psychiatric difficulties. Parents receive little to no assistance in discussing the overarching features of this condition from physicians or medical providers involved in their care, and data related to transition are virtually non-existent. This includes transition to adult health care, from school to vocational settings, from high school to post-secondary education opportunities, or even into independent living arrangements. Taken together, these challenges support the dire need to educate professionals regarding the nature of 22q11 deletion syndrome and its associated manifestations across the lifespan. By way of summary, Module 2 was designed primarily for educators, but also for practicing pediatricians and other medical providers. It is also designed to complement the information contained in Modules 1 and Modules 3. For Module 2, we have covered a number of salient issues with respect to 22q. We have addressed basic definitional issues of the condition. We've reviewed development across the lifespan. We've addressed in detail specific features related to neurocognition, academic functioning, and social behavioral features. We've spoken a little bit about measurement and evaluation and the critical need to obtain detailed and frequent measurement over the years across neurocognition, academic, social behavioral, and medical functions. And finally, we spent some time talking about management and intervention strategies and how not only can these change over time, but also the importance of linking these to a detailed and comprehensive evaluation. I am hopeful that this review has provided an increased understanding and appreciation of the issues and challenges faced by individuals with 22q11.2 deletion syndrome across the lifespan. We have discussed 22q as a genetic disorder that is from birth through the geriatric years. Interestingly, we know the least about the extremes of this age continuum. How an individual is affected will vary dramatically from one individual to the next, but we know about 25% will manifest a profile of abilities that is reflective of nonverbal weaknesses, including math deficits and internalizing forms of psychopathology. Importantly, though, most individuals will evidence a varied, heterogeneous profile of strengths and weaknesses. There is some sense that there is an insidious decline in neurocognitive functioning over time, and an increasing rate of psychotic symptoms and schizophrenia can be seen. Verbal IQ, attention, executive functions, and processing speed all have been identified as potentially declining functions as children age. Long-term academic and learning challenges are present, with specific deficits being reflected in math and reading comprehension. The psychotic symptoms and schizophrenia disorders tend to emerge in late adolescence and early adulthood, with approximately 25% at risk for these psychiatric challenges. I am curious to learn if these same 25% are those who experience the nonverbal cognitive impairments. More generally, a large percentage of individuals with 22q will manifest some type of psychopathology even early in childhood, with anxiety disorders and ADHD tending to be most common. Importantly, many individuals with 22q with social difficulties do not receive treatments for these needs, and this is something that needs to be addressed imminently. Similarly, their neurocognitive and academic needs typically are not addressed in an adequate or thorough fashion, and the need for early intervention in this population is paramount. It is unclear how closely the overall functioning of individuals with 22q are monitored over the lifespan, particularly as they move into young adulthood, middle age, and geriatric years. We know that evidence-based interventions to address the neurocognitive, academic, and social behavioral challenges tend to be non-existent specific to this population, but one could argue that available evidence-based practices for academic and behavioral problems, such as one might see with the SRSD model or phonologic processing interventions for reading, may be quite useful in management and intervention for children with these challenges. 22q's specific evidence-based interventions to address the neurocognitive and social behavioral difficulties have begun to surface, with preliminary findings showing positive changes following these treatments. Similarly, pharmacologic treatments also have shown positive changes, but these have not yet been studied systematically outside of small samples. Future clinical efforts should address comprehensive assessments, systematic developmental surveillance, and the need for effective interventions to address the needs of this genetic condition. Thank you for listening and watching, and I hope you will take advantage of modules 1 and 3 as you learn about 22q11.2 deletion syndrome. Thank you.